and welcome to Psychiatry Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for our presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please submit into the Q&A chat. A link to the event evaluation will be posted in the chat section. It is my pleasure to introduce Dr. Samuel Dodson, our Psychiatry Program Director.
Thanks, everybody. It was a great pleasure I get to introduce to you guys Dr. David Beckman today. David Beckman grew up near Philadelphia, and he attended the University of Pennsylvania for his medical and public health training. He then completed residency in adult psychiatry and fellowship in child psychiatry at Mass General McLean in Boston, and then continued to work there in that program where he became board certified in addiction medicine. Dr. Beckman returned to Philadelphia in 2021, and he's currently an associate professor of psychiatry and human behavior at Thomas Jefferson University Hospital and Sidney Kimmel Medical College. At Jefferson, he serves as the training director for the Child Adolescent Psychiatry Training Fellowship and oversees the department's efforts to build community partnerships and runs a clinic for youth with high-risk substance use. He's particularly interested in developing and implementing models of care that are appropriate and accessible to people who have psychosocial disadvantage and are members of marginalized groups. And on a personal level, I first met Dr. David Beckman when I was a resident at Mass General, and he was my mentor and we met weekly for chief supervision when I was a chief in my PGY4 year, and I still see him at national conferences. He is a little bit of a quirky guy and is very beloved by his residents and his fellows. And so it's my pleasure to introduce David Beckman. Thank you.
You call him quirky, Sam. No, I appreciate that very generous introduction very much. And, this is a really big topic to try to talk about in an hour. And I recognize that virtual grand rounds can be, a little bit of an awkward format. It is what it is. I think that maybe holding questions to the end does make sense, but I'm going to endeavor to leave a good amount of time for questions. And also, if anyone does want to just jump in and ask anything, I'll do my best to monitor the chat. I always like making things a little more interactive when possible, but recognize that it's a challenging format. But again, David Beckman worked a lot with youth and young adults who have often substance use disorders, often in the context of really significant trauma, including in places where the focus is on LGBTQ plus youth, as well as youth who are experiencing homelessness. Some pretty specific populations, but I think a lot of what I'm going to talk about applies more broadly. Hopefully things are advancing. There we go. Okay. I have no financial disclosures. I'm going to share my email at the end if you want to be in touch and let me know how I can get some. But anytime I talk about medications, pretty much everything is going to be off-label because very little is FDA approved in youth, and really nothing is approved for the specific indications that we're going to be talking about. So I want to start with this thought question that I ask my trainees in a lot of different situations. Is it better to treat diagnoses or symptoms in psychiatry? And here you are at Grand Rounds at an academic medical center, and probably the answer that most people's heads are going in that context is to treat diagnoses. And that's because that's really where most of our evidence base comes from. I've read all these articles about how to treat not depressed mood, but major depressive disorder, right? That's how participants are selected for these studies. To give kind of the Mickey Mouse example, if we treat the symptom of depression without thinking about diagnosis, then we're going to treat sort of reactive grief the same way that we treat major depressive disorder, the same way that we treat bipolar depression. And obviously that's not going to go particularly well. On the other hand, I want to acknowledge that sometimes our diagnostic entities fall apart a little bit when we're talking about more marginalized populations, and the evidence base is really limited. And so when do we have to maybe think about what symptoms are we targeting? So I took out some of the case-based stuff for better or worse, just to save time. But, I do want to just paint a little bit of a picture of the kind of case who I may end up seeing. And I'm going to guess that some of these details will sound familiar to some of you. So this was a very memorable young woman who was living with her aunt and uncle. She was living with them because her parents had their own substance use disorders and mental illness. They were quite physically and emotionally abusive. And so the patient kind of came willingly to treatment. She was reporting really severe depression, uncontrollable mood swings. She recognized that her mood was really reactive in a way that was uncomfortable, and also getting her in trouble at home and school. She was quite impulsive. Her aunt and uncle were really worried about that. She was sort of worried about it, but acknowledged that she was having sometimes less than safe, for example, sexual encounters with older men. And then there was the substance use. She was using quite a bit of cannabis, typically throughout the day, at least 3 times a day. And she started from a more ambivalent place than a lot of my patients do. It has no downsides. It's natural. It only helps. She actually recognized some ambivalence. She could say, like, this keeps getting me into trouble, and I don't want to need this. And then at the same time, she was saying, it's the only thing that keeps me out of worse trouble. So she's the kind of patient who you might have somewhere in the back of your mind. Because, thinking about a patient like this, how do you diagnose those types of behavior in this context? Do we say that it's mostly about depression and irritability? So we're going to think of this through a mood lens. We know that she's had a lot of trauma. Is this maybe more PTSD? How much of this is kind of secondary to the substance use? If she meets criteria for a substance use disorder, does she also have like a substance-induced mood or anxiety disorder? What about personality disorders, especially in someone so young? Some of the impulsivity and interpersonal stuff certainly could fall under those cluster B traits. She had a lot of features of anxiety. She was also acting in this really sort of oppositional and defiant way. Should we be thinking more about those kinds of diagnoses? So the point is that when you have a lot of trauma, when you have a lot of substance use, things get really messy really quickly. And it would be really nice to say, okay, well, let's clarify the diagnosis and then treat based on the evidence for how we best treat that diagnosis. But in reality, we can't always do that. So the objectives for the next 50 minutes or so are for people to be able to describe a little bit more about the relationship between trauma and substance use and why these are things that often run together, to outline what evidence base is out there about how we approach this population, recognizing that the evidence base is really limited. And then hopefully I may, depending on time, skip some of the middle, but I want to spend some time in the end and talk about really kind of practical considerations for how do you at least start to approach a patient who fits some of this profile. So we're going to talk quickly about trauma and trauma-related disorders in youth, then about substance use and substance use disorders in youth. Then we'll kind of put those together a little bit. Is it just the sum of the parts, or do we get some chemistry happening when we combine those two things? And then, as I said, kind of trying to put some of these ideas together into at least something that has some clinical utility, and go our merry way. All right. So to start with, just to point out what I think you probably all know, trauma is common. So according to a 2014 study, these are some of the estimates of the prevalence of different types of trauma. It's about 10% of youth have experienced sexual violence. Probably an even higher number have experienced physical abuse or violence. If we expand beyond interpersonal types of trauma, so disasters, natural disasters, that number climbs even higher. And then I think it's also just worth saying that I'm going to say more about this in a minute, but when we talk about trauma, we tend to think about, what happened to this kid. But what about witnessing other types of, really scary or dramatic or traumatic things, witnessing domestic violence, witnessing community violence? So you can see really common. If you want more recent data, so some of you are familiar with the Youth Risk Behavior Survey. So this is sent out by the CDC to what's supposed to be a representative sample of youth every 2 years. Thousands of high school students fill this out anonymously. And, these numbers look pretty similar. So sexual violence, around 10%. Bullying, quite a bit higher than that even. And, of course, this is not distributed equal amongst the population, particularly when we're thinking about sexual trauma, that women are much more likely than men, girls much more likely than boys, and LGBTQ queer identifying folks are much more likely to be bullied and also much more likely to experience sexual violence. Just working on my navigation here. So does that mean that, all of these youth have PTSD? If rough kind of back of the envelope, we're going to say that maybe 20% of youth have had a really significant trauma. Do 20% of youth have PTSD? And, the answer is no, but why not? So PTSD in youth, the diagnostic criteria for teens, really for anyone over 6, is the same as in adults. So you have to have had this exposure to the threat of death, serious injury, or sexual violence. So has to be this specific moment in time where I really thought I was going to die, or I really experienced or thought I was going to experience sexual violence. So you can see how that would omit things like witnessing violence or being exposed to kind of a lower level of trauma over time. You have to have that kind of flashbulb trauma. And then you have to have symptoms in these 4 clusters. So intrusions, that's things like nightmares and flashbacks, avoiding things that remind you of the trauma. Changes in arousal and reactivity, so that's the irritability and recklessness, hypervigilance, and then negative changes to mood or cognition. So, people can have really profound depression, distorted views about themselves and the world, etc. And so what I really want to kind of make the point here is that most people who experience even really significant trauma don't go on to develop PTSD. So when you are evaluating someone and they screen positive for trauma, you don't want to just ignore that information. It may have a lot of utility, in fact, but what you don't want is for your mind to now go into PTSD mode. I need to really evaluate for all the signs and symptoms of PTSD, and I don't need to worry so much about everything else. Because the truth is that trauma typically, most commonly, does not lead to PTSD, but it is a risk factor for many other things, including many other psychiatric problems. Psychotic disorders, mood disorders, anxiety disorders, substance use, which of course we'll talk more about. And then again, what about what is sometimes referred to as little t trauma? What if I didn't have that moment where I thought I was going to die, but I grew up never knowing where my next meal was going to come from? How does that overlap with what we see in kind of acute trauma? And to get an answer to that, it can be helpful to expand a little bit beyond the primary psychiatry literature. And some of you are going to be familiar with adverse childhood experiences, or the so-called ACEs studies. It's originally kind of came out more of the sociological literature decades ago. And then this study was kind of formalized by the CDC and Kaiser Permanente in the late 90s, expanded to bigger data sets in the 2000s. And they defined these very specific types of adverse childhood experiences. And they went around to, it's now been looked at both retrospectively and prospectively. How many of these things did you experience as a child? Were you physically abused? Were you sexually abused? And then, same for these categories of neglect and then household dysfunction. So someone in the house who had a substance use disorder, divorce is on the ACEs list. And when you define adversity that way, again, it turns out that this is really common. About 70% of the population has had at least one of these things. And when you think about things like mental illness in the family or divorce of parents, that's maybe not so surprising. As you go up in the number of ACEs, the number of people who have had that many decreases, but about 10% of the population have had at least 5 of these ACEs. And the number of ACEs that you have, or the kind of burden of adversity, turns out to matter. And then I'll just point out 2 kind of specific things about these ACE studies. One is that they found that the biggest demographic risk factors were low SES. So people who are kind of coming from less privilege are perhaps unsurprisingly more likely to experience some of these things. And then also, in line with what I've already said, identifying as queer is a major risk factor as well. Other types of specific, like marginalized groups, particularly ethnic and racial minorities, turns out not a specific risk factor for the number of ACEs experienced. But one of the criticisms of the structure of the ACE studies is that, they didn't take into account more community or structural violence. If I'm afraid if things in my home are going really well, but every time I leave my house, I'm worried that I'm going to get shot, or I'm worried about the racism that I'm going to face. How does that fit into this? But what was clear from these studies is that basically the higher the burden of adversity, the amount that it affects all kinds of outcomes, negative outcomes increases. So just to show you a few socioeconomic outcomes here. So to orient you to the graph here, so 0% is for people who have had no ACEs. How likely are they to have a felony charge, for example? And so because they are the index group, people with no ACEs are no more likely to have a felony charge than other people with no ACEs. But someone who has had one of the adverse childhood experiences, just one is enough to increase your chances of having a felony charge by 50%. Having 4 or more, enough to increase it by 200%. And, I could show you similar graphs for cardiovascular disease, for mental illness and substance use. In fact, it is estimated that about a third of mental illness is attributable specifically to this type of adversity. But again, don't get too bogged down in the specific ACEs because they are imperfect. A study that came out just last summer, summer of 2024, finding what probably doesn't surprise a lot of psychiatrists, but that basically exposure to systemic racism can spark both internalizing and externalizing distress and behaviors in Black youth. There isn't a specific ACE around housing stability either, but again, another recent study, perhaps unsurprisingly, that having unstable housing as a younger child results in all kinds of negative outcomes, even as we follow people into adolescence. And I don't expect that suddenly they're going to catch up with their peers in wellness as adults. And I think that does also make us think about what's going on in our world right now. What if we're worried about the impact of things like racism and housing instability? How does it feel to be a child who is worried about being forcibly separated from their parents or themselves being deported? And, the honest answer is we don't have a lot of data. This is a really rapidly evolving scene. The current administration has also not made it easy to study this kind of thing. So it's hard to put really specific numbers on it. But, there were some studies based on some of the family separation interventions in the first Trump administration. And, some of the numbers that were found from this study, for example, this looked not at PTSD diagnoses or other outcomes, but just looked at sort of the specific diagnostic criteria for PTSD. How many of those symptoms do people have? And found, perhaps unsurprisingly, that a kid who experienced an immigration raid, someone who was afraid that a loved one would be deported, or experienced the deportation of a loved one, were much more likely to have more symptoms. Someone who had a parent deported was more than twice as likely to have significant PTSD symptoms. So, hard to put as many numbers on it, but we know that we are putting our youth at really significant risk with some of our policies. And so, talking about PTSD and the fact that not everything that comes after trauma is PTSD and that it's a risk factor for all of these other things. But I do want to introduce this concept of complex PTSD, which is something that maybe some of you have heard of, and maybe not. Not sure kind of how attendings talk about it there, if this is something that people are critical of or buy into. I'm not trying to convince you to use this diagnostic entity, but I think it can be a useful framework. So complex PTSD is something that it's a term that was coined by Sky Herman in the early 90s, and it essentially liberalizes the definition of trauma. So it doesn't have to be that kind of flashbulb memory. It can be more lower level but repeated trauma, usually in early childhood, though it doesn't have to be. And then it adds another symptom cluster. So we've got the same intrusions, avoidance, arousal and reactivity, and negative cognitions and mood that you see in typical PTSD. But then you also have these, quote, disturbances in self-organization. So that's affect dysregulation, negative self-concept, and difficulties in relationships. And so just, as a quick history, the DSM-5 came out in 2013. This was a debate among the trauma working group. Do we include complex PTSD as a separate diagnosis? Ultimately, the APA decided not to, so this won't be on your board exams or PRITES or anything like that, though the World Health Organization does recognize this as a separate diagnosis, so it is, you will find it on like ICD-11 codes. Again, not trying to convince you one way or the other, but just to point out that people who go through significant adversity, yes, they can have a lot of PTSD symptoms, even if they don't meet criteria for PTSD. But these kinds of things, the affect dysregulation, the negative self-concept, and the difficulties in relationships, these are also really common sequelae of trauma, particularly childhood trauma, even in someone who doesn't have PTSD. And so when you add those diagnoses or those criteria to the diagnostic criteria of PTSD, it starts to sound a lot like this, a pattern of instability of relationships and self-image and affect, and with these things like unstable relationships and impulsivity, affective instability, intense, difficult to control anger. So probably many of you are recognizing that these are the diagnostic criteria of borderline personality disorder. And so again, my goal is not to tell you to be using this complex PTSD diagnosis or not, or to be more or less liberal with diagnosing personality disorders. But I do think that it is useful to think about the fact that there is at least some element of all of these diagnoses that we're talking about that exist on a spectrum and that stem out of some of the common sequelae of trauma. And by the way, just as a very quick aside, can you diagnose that 17-year-old patient with borderline personality disorder? You could. There's nothing saying that you can't, there's no magical, you have to be 18 to be diagnosed with a personality disorder, with the very specific exception of antisocial personality disorder. People sometimes conflate that and overgeneralize that rule. But, what is the purpose of our diagnoses? What are you really trying to communicate here? So I'm not going to go through the neuroscience of this. That would take the whole time, and I would be pretending to have much more expertise than I have. But the point is that smarter people than me have spent their lives studying the ways in which early childhood adversity can really substantially rewire the brain. And clinically, the person who's probably best known for summing up the effects of this is Bessel van der Kolk, who's a little bit of a controversial figure in his own right, but wrote the very famous The Body Keeps the Score. And to kind of sum up the clinical pieces of this, his quote is that prolonged and severe trauma, particularly early, tends to result in chronic inability to modulate emotions. I think that's really important. And some of the common sequelae of trauma, regardless of specific diagnoses, are difficulties with attention and executive function. So navigating the world becomes more challenging. Difficulties with sort of your own identity and your expectations of yourself in the world. So it's very uncomfortable just to be in the world. And then emotional and behavioral regulation and stress reactivity. So you if you imagine sort of always feeling very uncomfortable in your own skin, and then it doesn't take much to kind of set you off and feel even much worse, you can imagine just how uncomfortable that would be. And it leads to this kind of perfect storm for really decreased distress intolerance, or decreased stress tolerance, I should say. Even little things can make life so much more difficult. And so if you do think that your pediatric patient has PTSD, how do we deal with that? The gold standard is CBT. Turns out there are no medications that are FDA approved. There are really no medications that are even well researched in youth. So do we just reach for the adult literature and say, let's try SSRIs? It turns out that in the PEDS literature that SSRIs don't do so great for PTSD symptoms. But if our patient is old enough, is she close enough to an adult, that's where we should start. There have been other studies that have found some utility of other medications, but not a great evidence base. What is the risks and benefits of trying some of these things? And particularly atypical antipsychotics. They have been found to really relieve some of these symptoms, but they also have a lot of downsides. And perhaps it's not surprising that they relieve some of these symptoms because they're really blunt instruments. They hit a lot of receptors, do a lot of things, but that also brings with it a lot of potential side effects and toxicity. So, when do you reach for these bigger guns? And so again, if we think about this through an adult lens, then maybe we do start with an SSRI or venlafaxine and go through some of these published sort of flow charts to figure out what medications we most want to use. Though these are very imperfect and based on really limited studies. And I do just kind of want to make the point that when you get to the end of this flow chart here, it starts to break down. We don't have these great studies saying, well, this kid with PTSD, let's add this. And it starts to get more about more about symptoms. I'm having really a lot of hyperarousal. So maybe I should go in kind of a more quetiapine or clonidine direction. And, again, not trying to be really specific about meds here, but just to point out that when you are in this zone where the evidence base for what you can treat from a diagnostic lens is limited, maybe sometimes the best you can realistically do is to target symptoms. And so, yeah, I think I've said all this, just going to keep going in the interest of time, but I'm going to show you one more chart. This is from a analysis looking at ACE studies. So these are those 10 things that I showed you before, but this is just a nice little, I think kind of an elegant study where they looked at, this was a meta-analysis of twin studies in ACE protocols. And so basically you take the twin who has adversity, you compare them to, the adopted twin or the not adopted twin or differently adopted twin who doesn't have the same adversity, and you see, how likely are we to have these more negative outcomes when you keep the genetics the same. And these ones that have the bigger error bars are because they're smaller cohorts, because they're just looking at monozygotic or dizygotic twins. But when you look at all twins, these error bars get quite a bit smaller. And basically the way to interpret this chart is that for every adverse childhood experience you have in your history, your chances of each of these things going up increases by about 60%. So that's depressive disorders, stress-related disorders like PTSD, anxiety disorders, and substance use disorders. So let's talk a little bit about substance use disorders in youth. This will be shorter, but substance use also quite common. Turns out not quite as common as it was. So even compared to 10 or 15 years ago, the amount of high schoolers who are regularly using alcohol has gone down a little bit. It's true across different ethnic groups. There we go. Same with prescription opioids. They've stayed about the same, but though we talk a lot about increases in substance use among youth, it actually turns out that that is not the case. Even cannabis, where it can feel like, depending on who you're talking to, every teenager is smoking an enormous amount of weed. I certainly hear that a lot from my teen patients who are smoking. Like, yeah, of course I am. Everyone is. It can be helpful to sometimes normalize that a little bit and point out that, actually it's a fewer than 1 in 5 high schoolers who have used any kind of cannabis in the past month. Again, pretty similar by race and ethnicity, though in this example, Asian high school students are much less likely to be using cannabis. And I'm not going to spend time going through the DSM criteria, but just to point out that, if it is interfering with someone's functioning, that's mostly all you need. You need 2 of these criteria for someone to otherwise meet for like a mild substance use disorder. But it's very hard for someone to have any kind of significant substance use that's actually getting in the way of their life in some way and not meet several of these. That said, I will also make the point that these criteria, though they're the same in youth, they were not designed with youth in mind. And so it can be harder to apply these to younger patients. So, for example, some of these continuing to use despite it getting in the way of things. A lot of teens don't have insight into the way that substance use is impacting their school or family life or things like that. Withdrawal is another example that younger patients tend to have much less physiologic withdrawal than older patients do, and can, get away with a lot more alcohol, for example, and not think I'm drinking too much because I don't get hangovers, I don't get withdrawal. And how do we treat substance use disorders in youth? We could be here all day just talking about the evidence-based therapies. I think you probably all have the sense that talk therapy is more of the mainstay of treatment than medications, and that is true. And there are a lot of different evidence-based therapies for use with substance use disorders, regardless of the substance. All of these have a significant evidence base behind them. Some of them can be combined very effectively. And, I'm not, obviously can't kind of go through what all of these are or what the evidence is, but I am going to highlight just for a moment motivational enhancement therapy. So some of you will be more or less familiar with motivational interviewing. Motivational enhancement therapy is essentially just like a manualized version of MI, but MI is not a therapy. Motivational interviewing, it's a toolkit, and it's a toolkit that I think is just incredibly useful as psychiatrists. And we think about it mostly in the context of substance use, but it's all about trying to find patients' intrinsic motivation to change and promoting that change. So it can be used for medication adherence or getting someone to agree to meet with a therapist or whatever it is. And so I'm not a paid spokesperson in any way, but I do recommend this book, Building Motivational Interviewing Skills. It's just like a really practical way to practice some of these skills. It is literally a workbook where you fill in answers to questions. And so especially if you're working with young people, especially if you're working with substance use disorders, I highly recommend at least practicing some of the basic skills. And I will, with our limited time, just take 2 minutes to talk about the spirit of MI, which is that even, if you know nothing else about the really specific skills of MI, you have to come from this place of collaboration, meeting people where they're at, approaching patients without blame or judgment. Promoting their autonomy. And then the name of the game is, how do I get you to talk about reasons why you would want to change? And that's where those other skills come in. But you have to start from this place of, tell me where you're at, tell me how I can help you with your goals. If you sort of wag your finger and say, alcohol is bad, people don't like to be told what to do, and particularly teens. And one way that I kind of, in my simplistic mind, like to conceptualize this is the old devil and angel on your shoulders, that like in the old Warner Brother cartoons. And the idea here is, the devil sort of whispers, oh, you should do the bad thing. The angel whispers, oh, you should do the good thing. And your conscience sort of battles it out inside your head. And so in this example, it might be the devil saying, of course you should smoke weed. It's not bad for you. It's natural. It makes you feel better. It doesn't have any downsides. And, you like it. You work hard at school. You deserve a break after school. And then you've got the angel, the other side, saying, you should probably lay off the weed. Your grades have gone down. Your parents are always on your case. You're not doing competitive sports anymore. It must be affecting you in some way. And the truth is that almost any kid who is smoking weed really heavily or drinking enough that someone is concerned about it, even if they can't voice that ambivalence, they are almost certainly feeling some degree of ambivalence. There is some kind of voice to change and to not change in their head. And so human nature is to say, well, this kid already has this angel kind of telling them the reasons to make a change. I'm going to join that chorus. I'm going to join in, and together the angel and I are going to overpower the devil. I'm going to lend my expertise to what this kid is already thinking, and they're going to change. But as probably many of you have experience with, it just doesn't work out that way. The problem is that if I start kind of yelling at you all the reasons why you should change, what I'm actually doing is not so much joining the chorus of the angel as I am taking over. If I have these two internal voices battling it out, and then this external voice comes in and starts making one of the arguments, then my natural inclination is to keep that argument going. And the way to keep that going is to give voice to the other side. And, this is not unique to motivational interviewing. This idea pops up even in like psychodynamic and psychoanalytic theory called splitting the ambivalence. Probably most of us can relate to this. I mean, I know I've certainly had times where I've said, like, I really can't decide between, do I want Mexican food or Chinese food? And can't decide. And so I'll say to my spouse, like, what do you think we should get? And she'd say, well, we haven't had Mexican in a while. Why don't we do Mexican? And it's just this kind of knee-jerk reaction. Well, wait a second. Have you thought about how delicious Chinese food would be tonight? So just to keep in mind that when I'm encouraging you kind of not to sort of tell teens what to do, it's not because we need to be cool or we need to, teens need to think that we're super neutral and we don't recognize that there are risks of substance use. It's because we're really trying to emphasize autonomy and emphasize a teen's own motivation, and telling them what to do is just very unlikely to work. So in terms of medications, though, because we're a psychiatry crowd and that's often the biggest piece of what we're doing. So first of all, what are the FDA-approved medications for youth with substance use disorders? So one is that for anyone who has opioid use disorder and is at least 16, buprenorphine is FDA approved. Oh, whoops. All right, yeah, so it turns out there is not a lot. And so if there's another take home that I would really emphasize from this, it's that, you shouldn't be afraid to use medications that have an evidence base, even if they're not FDA approved. And so that's basically all of the same things that we would be using in adults. There are practical considerations, of course. Good luck finding a methadone clinic that will take a 16-year-old. So, buprenorphine might be the better one there. But there are no FDA-approved medications for youth with alcohol use disorder. Does that mean you wouldn't use naltrexone or acamprosate? The truth is that we get, especially with kids, we get really worried about the risks of our interventions. I am maybe especially like I'm not even a child psychiatrist. This is off label. I'm not supposed to do this. What if they have a bad reaction? And that's fair. There is inherent risk in this. But there is also inherent risk in not intervening, right? And so I would argue that for the vast majority of youth who have a really significant alcohol use disorder, that the risk of not treating that is far, far greater than the risks associated with putting someone on Vivitrol, for example. I am also just going to make this quick aside here, and I realize I'm getting to the end of the time, but for cannabis use disorder, because that is a lot of what we treat in the youth population. And just to point out that, some people may not be familiar with this data, but that N-acetylcysteine, or NAC, it's available over the counter. It's regulated as a supplement, not a pharmaceutical. I picked a random picture offline. I don't sort of support or endorse any particular companies, but it works in the NMDA system. It's in the reward pathway, and so there was a lot of interest in NAC as a potential intervention for substance use disorders. Most of those studies were really disappointing. The exception was that it was actually helpful in getting youth who are trying to cut down or quit using cannabis to do so. That has been replicated in youth, and youth in these studies is typically defined as 25 or under. And yet every time it's tried with older adults, and in this case, by older adults, I mean over 25, it does not pan out. So why is that? I really have no idea. It's feasible that it has something to do with differences in the developing brain. I think it's much more likely that the cohort of teenagers with cannabis use disorder have sort of a fundamentally different relationship with cannabis than a cohort of older folks with cannabis use disorder. But I don't think anyone really knows the answer to that. I will also say that there is some admittedly limited evidence for other medications that we use in psychiatry to, at least to some extent, target some cannabis cravings, including gabapentin and quetiapine. Though again, these are medications that are not without risk, and there's always going to be that balance. So, in my last few minutes, other kind of thought questions. So someone comes to you and they have a lot of trauma-related symptoms and a substance use disorder. How do you prioritize? Not going to poll the audience, but you treat the SUD and then you can address trauma symptoms. That was really the standard for a long time until quite recently. A decade ago, certainly 2 decades ago, you take a kid to a child psychiatrist and say, my kid is smoking weed every day and also is depressed. The most common response that you would get is, okay, bring him back when he stops smoking and we'll work on the depression. Turns out that just does not work very well. That trying to treat psychiatric symptoms in the presence of a substance use disorder is really hard, and the reverse is also really hard, and that your chances are going to be much better if you can try to address both things simultaneously. Now, holistic integrated treatment may not surprise anyone to hear. Yes, that is the ideal. That is the best if you can get it, but at least making sure that both things are being addressed is really important. So in the interest of time, I'm going to skip a few slides here. But, what I'm going to kind of end by talking about some practical considerations. And to set that up, I'm just going to have one more kind of Mickey Mouse graph here, that we've already talked about how trauma can lead to this kind of chronic psychic pain with high reactivity, and that we're talking about maybe treating that with therapy, maybe treating that with like an SSRI or venlafaxine. Maybe the kid is thinking about sort of self-medication with a substance of misuse. And, just to think about that from their perspective, that therapy might be really hard to tolerate, or their idea of therapy might seem intolerable. I'm not going to go talk about my trauma for an hour every week. SSRIs can also be a really tough sell. I know that smoking weed makes you feel better right away, but you should probably stop that, take this pill every day, and maybe in a month you'll feel a little better. That's a tough sell. Whereas, substances of misuse, they genuinely do provide relief. The problem is that this feeds back and eventually makes things even worse. And we have to figure out how to break this cycle. So having a discussion where you're sort of trying to explain this in a developmentally appropriate way and a way that they're ready to hear, I think is important. So concretely, you're always coming with from a place of collaboration and the youth's goals. A lot of lines that I use with youth are something along the lines of, I'm not a priest, I'm not a cop, I'm not here to judge anything morally, or even to tell you what you should do with marijuana. But you are telling me that you feel like you have to smoke every night. And I don't want you to feel like you are not the one in control. It's also really important that you validate youth's experience and that you acknowledge the limitations of what you have to offer. And so that goes back to recognizing that in the short term, substances can be really helpful, and that, people are looking for that kind of quick fix. If I can feel better from drinking alcohol, why can't you give me something that sort of removes my trauma more permanently? As treaters, we know that that's not realistic, but that's like really unfair, right? I mean, nobody asked for this trauma. And so helping people recognize that, yes, it sucks that there isn't the kind of quick fix that we all wish that there were. And we want to work together to, getting you to where you want to get, even if it takes longer than we want it to. You are often, as a psychiatrist, leading the ship here. And so who else can you recruit? Who else is on the treatment team? What kind of psychosocial interventions are in place? What is the role of family? For youth who are living at home, if their parents or other family members aren't involved in treatment, things are much less likely to go well. And at the same time, parents might have their own substance use issues. Kids might be not willing to disclose accurately what they're doing to their parents. And so balancing family involvement with youth confidentiality can also be really important. Checking in about all substances at all appointments, because again, if you try to check off one of these first and then move on to the other, probably not going to go really well. That you're going to try to give good substance-related care. So you have to meet them where they're at. If someone says, weed is great, no downsides, and you say, okay, we'll take, 4 tabs of NAC every day and your cravings will go down slightly, like that's not going to do anything. It's going to help if there is motivation. And if there's no motivation, you've got to start there. You also have to have a sense of what's actually in someone's body. So laboratory monitoring brings some more objectivity there. But it's also really important that patients don't feel like this is a gotcha or I'm going to immediately run to your parents with the results. So they need to understand that this is so we can talk about what's going on and I can make sure I know what I'm treating. Psychosocial interventions are going to be so key. And then when it comes to meds, you want to be informed by the evidence base rather than FDA approval. And then again, with trauma-related care, psychosocial interventions are probably more key than medications. And what about meds? So in my last 2 minutes, gonna just say for meds, is it better to treat diagnoses or symptoms? And the answer is probably it depends. If you have a clear diagnosis, if you really know what you're treating and you have an evidence base you can turn to, great. But there is essentially no literature that says, here's what you should do with this population. And so you may need to think about if this patient has symptoms that some overlap with PTSD, some overlap with borderline personality disorder, some of that affective instability that we associate with trauma. Is it better to target that with a mood stabilizer? And it does often come down to what are the most problematic and concerning symptoms. So just to, compare some examples of medications that I thought about in this case, starting an SSRI would be the standard of care in adults, not FDA approved for this indication, but it is in other indications for youth. Well, actually, that's not true, but it's at least well studied in youth. Really little risk, but takes some time to work. And, how much time do you have? How much buy-in do you have from the patient? Are they going to take up a medication every day if they're not feeling that immediate benefit? Versus something like quetiapine, which has a much stronger evidence base in borderline personality disorder. It can bring some immediate relief for some of the things that people are turning to for cannabis in this situation. It can still have long-term benefits to mood and anxiety, maybe some benefits for targeting cannabis, but also significant metabolic toxicity. And so there isn't necessarily a right answer here. But, you do want to think about this idea of first do no harm and not necessarily jumping right to things that have more risk. And at the same time, thinking about the risks of actions, but also of inaction. And if I don't do something that's going to bend the trajectory of this youth's symptoms and behaviors sooner rather than later, are there even bigger risks? And, if we're talking about minimizing risk, then it may not be super intuitive to think about actually prescribing both of these medications. And yet I've done that too. And in fact, that is what we ended up doing with this patient. The logic being that I'm hopeful that quetiapine is going to really help her in the short term. But in the meantime, want to get some buy-in that medications actually can have a role, meds can be helpful. Let's be ramping up the sertraline in the meantime and aim to not have you on quetiapine in the long run. Right. So I'll close by saying that trauma and substance use, problematic substance use are really common and so important to screen. They're both great imitators in psychiatry, so important to screen. If someone's coming in with mood symptoms, could be mood, could be trauma, could be substance use, and that these are risk factors that play into one another quite a bit. So really useful to talk with youth about the relationship with a substance, what it does for them. That the specific evidence base in what we're talking about is really limited. And so you want to consider diagnoses as much as you can, but also you may need to think about what are the most problematic symptoms to target. That the more you can integrate or at least have simultaneous treatment, the better. And you want to involve as many psychosocial modalities as you can. And this is mostly from the substance use literature, but that individual therapy groups, guardian involvement, peer support, that all of these things are not only individually helpful, but also synergistic. And then finally, it's essential to have a non-judgmental approach to maybe consider learning more about MI, motivational interviewing, that all treatment carries risk, but that under-treatment can carry even more risk. So think about your evidence base more so than just what's FDA approved. And that even psychiatrically speaking, sometimes some situations may call for higher risk medications, but it is once again always balancing the benefits and the risks. So I'm going to stop there. I think I have at least a couple of minutes if there are questions. I ran a little longer than I meant to, but there we are. Stop presenting. And if there are any audience questions from the chat or the audience.
Hello, my name is Amanda. I'm a PGY4 resident, and I had a question. In your experience, what therapeutic modalities have you had the most success with patients who have complex PTSD?
Yeah, that's a really tough one. There is this, there is a literature about therapies for complex PTSD, and there's this guy, probably Courteau, probably going to say his name wrong, but there is a sort of CPTSD specific therapy that goes through kind of 3 phases. The first phase is all about alliance building and recognizing that this has to be psychologically safe before we can talk about trauma at all. And then the second part is kind of about trauma processing. And then the third part is sort of how do we move on here and make your life look more the way you want your life to look. So I think that that's kind of the ideal in some ways. And there are lots of different kind of trauma-based therapies that are some variation on that. The question is, what is realistic in terms of accessibility and what you can get covered by insurance and what someone can get to, et cetera. I would say that to some extent, the perfect is the enemy of the good, and someone who has experience with this population, probably almost any type of therapy is going to be worthwhile. I think there is some risk in someone who's really inexperienced with trauma. Just, it's a can of worms that you don't want to open if you don't know what you're doing. But I don't necessarily have a better answer for you, but I think that the trauma-based therapies, sort of trauma processing-based therapies are probably what you're ideally going for.
Hey, Dr. Beckman. My name's Joseph. I'm a PGY4 here as well. Appreciate you talking with us. If you could summarize, we often do see complex PTSD as a stand-in for maybe folks that someone suspects with borderline personality disorder. How do you go about differentiating that? And do you find it useful for treatment when you do that?
Yeah, I mean, I think this could be kind of a whole talk in and of itself, that the complex PTSD is sometimes just code for borderline personality disorder, and I would argue that that's that is problematic in the sense that why do we need a code? And I think we could talk a lot about the stigma that is associated with borderline personality disorder, and I think that stigma, frankly, is changing with social media and other forces. But the reason that I kind of like complex PTSD as a diagnostic entity is because, frankly, part of it is just about language. I think that personality disorder, just as conceptually, the way we talk about it is problematic. It sounds like we're telling people that their personalities suck. And I think that it really under-recognizes the role of trauma in the development of maladaptive personality traits. So I don't necessarily think that it is inherently useful to diagnose someone with complex PTSD over borderline personality disorder, or for that matter, vice versa. But what I think is useful is to recognize that we have this evidence base for sort of garden variety PTSD, which is mostly about CBT and SSRIs. And then we have this evidence base that is more kind of borderline personality disorder, which is more about dialectical behavioral therapy or some of the other so-called third wave therapies, and more benefit from mood stabilizers. And so I think that it can be useful to have a way to talk with patients about their experience that resonates with them. So if someone really identifies with borderline personality disorder, fine, great, I have no objection to that. But if someone really doesn't, I think that complex PTSD can be a way to talk about some of these symptoms in a way that puts the trauma more front and center. I in this kind of oversimplified way, kind of think of PTSD and borderline personality disorder as a spectrum where complex PTSD exists somewhere in the middle. There's this whole literature about why they're categorically different. And I'm not saying that my way is the right way to think about it, but I think again, for me, it's just useful to recognize that this is someone who's had adversity. It is causing problems, at least some of which we know are associated with trauma. And now we're kind of on the spectrum where, from a pharmacologic perspective, and to some extent from a therapy perspective, maybe it's less useful to say, okay, well, you perfectly meet criteria for diagnosis X, so we're going to use intervention Y, and becomes a little more useful to think about, okay, you have this sort of spectrum of symptoms. We know we have different options. Which types of interventions are going to be the most high yield, at least initially, for the specific symptoms and experiences that you're having? I don't know if that really answers your question, but hopefully at least partially.
All right, we're at time. Thank you, Dr. Beckman. Great presentation. We appreciate your time.
Thank you so much. Thank you all for having me. If anyone wants to ask any follow-up questions or anything like that, I popped up my email, but you can certainly, Dr. Dodson can put you in touch with me, no problem. Always happy to talk to people, and good luck with the rest of residency for the trainees, and hope everyone has a great rest of their day.